Welcome to the podcast, Surgeons in 3D Printing. Today, I have the Head of Surgical Innovation 3D Printing Unit, the Deputy Director of the Orthopaedic Oncology Department, Dr. Solomon Dadia, from the Tel Aviv Medical Centre, Israel. Dr. Solomon has been at the Tel Aviv Medical Centre for almost 10 years. Let us connect with him for an insightful conversation. Welcome, Dr. Solomon.
Thank you for having me, Dr. Ruchi.
Thank you. And so I wanted to ask you to begin with, can you share your roles and responsibilities while heading the center?
Yeah, I'm working in Tel Aviv Medical Centre since 2002 in orthopedic oncology. I did my fellowship in Birmingham, UK.
Wow.
The Royal Orthopaedic Hospital. And since then, I'm a consultant in the Tel Aviv Medical Centre in the National Unit of Orthopaedic Oncology. In 2017, we started the project. At first, it was just a small 3D printing lab. But gradually we grew, and we are well established now in the hospital, and we are providing services to all surgical departments. It was just me at the beginning. Wow. And now we are seven employees, engineers and designers and 3D techs. Yeah.
Wow, so that's like this printing department, you can say, is like a baby of yours. You've been finding it like since like
absolutely.
now. Yeah. So how did you start with 3D printing as a technology?
Well, it starts from our need as an orthopedic oncology surgeons. In orthopedic oncology, we deal with very large bone resections, very large bony reconstructions, with the lack of solutions. So we are struggling with solutions, and the solutions are not so good, and because the population of patients is mostly children in primary bone tumors, primary bone sarcoma, it's making it even more difficult to reconstruct a growing skeleton of a kid. So we always looked for solutions. And I was encountered with 3D printing while I was in London working in the Imperial College. I was working in the MSK lab at Imperial College, London. There were a few projects of PhD projects with students that they used a EOS machine in the lab for their needs of their projects, and I started to look for solutions for orthopedic oncology while I was there. And since then, we started our few really initial cases while I was commuting to Israel, to Tel Aviv, to do the first cases.
Wow, that's really nice to know. But I was intrigued that what was your first case, like just out of curiosity, and because the first case is something you never forget. So what's your first case that you did, and how was success with that?
First case was a lady with a chondral sarcoma, a malignant tumor of the acetabulum of the hip joint. And back then, we didn't challenge ourselves fully with the 3D printing planning. We did the conventional type 2 internal hemipelvectomy. That's the standard way to resect a chondrosarcoma of the hip. But we used a jig. We used for the first time a surgical planning. We did a segmentation of the tumor volume and the pelvis. We planned a cutting jig, and this planning was done in the MSK lab in London. And I traveled to to do the operation myself. The reconstruction was a standard ice cone implant, as we do always. So it wasn't a custom implant, it wasn't a 3D printed implant, but it was the first surgical planning. And I think this made the impact. This made the impact for all surgeons, that my colleagues, that we can be more accurate, we can plan our resections, and then we can go further to plan our reconstructions. This was like a cutting point in our surgeon's mind.
Exactly. So you started with jigs basically and virtual surgical planning to begin with.
Yes. And then I think that the main principle in our services here in Tel Aviv relied on good segmentation, meticulous segmentation, and then meticulous planning. And I think execution is very important.
Exactly.
But I think if you put attention on segmentation process and then the planning, your execution in the OR, in theater, will be smooth.
Exactly. So were you involved in the surgical planning, or did you outsource that planning completely to the engineers or the bioengineers?
Well, at the beginning, we were debating how to do that in hospital, to do all in-house, also some of the steps outside of hospital. But I believe from the beginning that it should be inside, it should be in-house, it should be engaging with surgeons. And I'm quite sure after 5 years of establishing this service, I'm quite sure and definite that this is the way to do that. Even if you outsource some of your printing, at the end, the initial steps of segmentation and planning should be in-house, because this is a game changer. This is the game changer to recruit surgeons to segment. It forces them to think about the surgery. Because we are all as surgeons used to run from patient to patient, from surgery to surgery, no time for planning. And even if you think you plan, you don't. You realize that you are not paying attention on planning while you sit for 1 hour in our facility and then working with segmentation software and working with designers and engineers. And then you realize, whoa, it's mind-blowing. And then this is the process I would like to take every surgeon during this process, not to bring us or give us some data, the DICOM data, CTMR, and we will work on it and provide some products. This won't make any change in the habits of the surgeons, in his approach to the surgery. I think if he is a recruiter to the process, he must sit with us and think about the approach, think about every step during surgery, because it forces him to think. When you have to think about the footprint of a cutting jig, then he must think about how he would approach it.
Exactly.
Will it be a posterior approach? Will it be an anterior approach? What layers and what structures he will meet through the approach? And then when he will think about all these steps and he has a cutting jig in hand, I'm sure that eventually, while he is operating, he will do the same, like in an automatic way and a didactic way. And then he will minimize his exposure. He will minimize his exposure and blood loss, because he knows where to put the cutting jig. And I think it starts from the first step of segmentation and planning, and with the surgeon. Do not skip those stages.
Right. I loved your words that we think we plan, but we actually don't. And that's really true for a lot of cases, wherein we just move into the OT. We feel that we've planned because we've just looked at the case, but we actually haven't sat down to plan. So that's really a takeaway point there. Could you also,
Absolutely.
yeah, could you also then tell how did you build your team for the center?
Well, at the beginning, it was we worked with a small company of industrial designers. So they put their designers in the hospital. It was convenient because of the financial arrangement at the beginning. There was no budget for the project, so it was easy to bring inside the company a motivated company, a small one, of designers. That's the way we started to appreciate the designers' work in the medical field. And I know that most of the places in the world work with engineers, but I have a great experience with designers. So we had two designers at the beginning, sorry, and then it was designers and me, and we in the first few months we were approached by a 3D tech. This is a discipline we don't have in Israel. So he's American that works as a 3D tech in radiology in North America. And we are privileged to have him because he's like a liaison between the imaging world to the 3D printing world. So it's quite difficult to expect from an engineer or a designer to know anatomy, to know pathology, to understand the imaging, the different sequences, and how to build the best STL file from printing from the best sequence, the right sequence from the MR. And there are some quite complicated software of Fusion to understand the registration between modalities. So we are privileged to have a 3D tech that understands all this. And he sits in the first station of segmentation. And then we recruited two engineers, and then that's it comes with the need, it comes with the growing of the lab. And we are lucky that the management, so after a year, this proof of concept is very successful, and the surgeons from all disciplines start to use it, and we get the budget was bigger from year to year, and we could even export some work outside to bring some money inside, and now we are 7 engineers, designers, and the 3D tech.
Wow. So how did you get the budget in terms of how did you prove how did you get the proof of concept done with respect to proving your administration that this works? Because that's the difficult part to start with.
It's a difficult part because even till now there's no reimbursement of those cases. So exactly. It's quite tough. It's quite tough. That's why I focused in that proof of concept in orthopedic oncology. This is my field. I can control what I do, and we pushed a lot of cases of orthopedic oncology in the first year, and orthopedic oncology. It's like it's a cutting point and a turning point and changing point for orthopedic oncology, because you take a kid with and most of the sarcoma is around the lower limb, around the knee, and unfortunately with the tools we had before 3D printing and 3D planning were not so good for planning, so we tend to do radical resections, and they were losing limbs, they were losing joints. Even if it is 3 to 2 centimeters from the level of the joint and the distal femur, most of the surgeons around the world and here will sacrifice the knee because there's no good way to see where is your cut during surgery. Right. So we tend to do radical resections just not to jeopardize the patient in margins, in oncology margins. But when you plan, when you have a very good model, a digital model or a printed model, when the margins of the tumor is clear and you can put your osteotomy lines very close to the tumor, but still safe oncology margins,
Right.
then you can save a lot of bone. You can save a lot of joints. You can save limbs. Then we started to calculate our cases and looked at our cases. We did lots of joint saving, not putting a mega prosthesis. So a mega prosthesis the average price for a mega prosthesis is around £20,000, 20,000 euros. So you have just, if we do 30 to 40 per year, and we transforming a metal prosthesis that is very, very expensive through a biology reconstruction, because if we do just a geographic resection around the condyle and we save the knee, we will reconstruct only with an allograft that is only £1,000.
Right.
So this is very crucial. So it's like millions of saving for orthopedic oncology. So that's what my experience, and I saw that it's a huge proof of concept. So then it was easy to take, even because there are some surgical disciplines that you cannot prove
exactly
very easily this saving, because it's not quantitative.
Yeah.
If a liver surgeon, they do a lot of cases with us, so they look at the tumor, how it is, what is relationship of the tumor between the biliary tract and the vessels, and they use it as planning. But I cannot give them any tool to execute the procedure. So I can give them the model, but I know, and they are all the testimonials of the surgeons are that it is a big deal. It makes the difference, but I cannot give numbers.
Exactly. You can't quantify.
Yeah.
You can quantify in terms of that there has been less blood loss, maybe the time was saved, but in terms of numbers, it's a little difficult.
Yeah, but we are in a big project to summarize all it's about 800 cases. Half of them are orthopedic oncology, half of them are different disciplines. And we are now summarizing the data to understand in every and each discipline what are the advantages, and try to quantify the numbers even of all the blood loss and exposures and surgery time, rehabilitation time, hospitals, everything. We are now in a big project, and I think we are about to publish all our data, especially in orthopedic oncology and the others.
Wow, because that is going to be an eye-opener actually. So we'll wait to see that. Yeah. So I would like to ask you that what are the kind of cases that you're doing other than, in the lab, other than orthopedic oncology? Definitely, it does show that orthopedic oncology takes up the bigger chunk. But what are the other specialties which are taking advantage of the lab?
Well, of course, all the disciplines that work with bone, and it is neurosurgery for skull defects, it is spine surgery, pediatric spine works a lot with us, with scoliosis and congenital scoliosis, pediatric deformities. It's a big chunk of the work. They did quite a change in their approach to deformities, bone deformities, because they were correcting bone deformity and planning it in 2D. And it is because of difficulties to think of all the plans in correction, they were correcting it with a frame. And then they would do the osteotomy, put a frame, and then along a few weeks, they will do the correction gradually, according a plan. Now they are planning with us and planning in 3D, and then we can give them this planning in an acute multi-planar correction. So they are sparing the use of frames, and they are doing acute correction. It's amazing. So even there we can prove, and we prove the saving of those multiple surgeries and the comorbidities of the patients.
Wow.
Other disciplines are general surgeons works a lot with pelvic tumor, where they deeply seated pelvic tumors, liver, pancreas tumors. Eye surgeons and maxillofacial and ENT works a lot with us. All the mainly oncology of the base of skull and neck, and problems with the orbit, trauma surgeons works a lot, especially in pelvic fractures and complex knee fracture and tibial plateau fractures. And the plastic surgeon, we did a lot of work with plastic surgeons in all those cases with asymmetry of the face or breast, and the reconstruction. There is those surgery to reconstruct the breast after a mastectomy. So we give them models with the vasculature of the flaps.
Wow.
So they are planning their flaps according to our segmentation of the vasculatures and the muscle. They have to move sometimes in rotational flaps or sometimes free flaps, and it's all done and planned before.
So
there's
that's
a
amazing.
big variety of I think all surgical disciplines work with us. There are some surgical disciplines that are late bloomers, even if we are here, but there is always a case that is the first case that they think, oh, we'll do a model, we'll go to Solomon, and then I'm happy. No matter when they come, I'm happy, and one good first case will prove the point, and then they will stay with us.
Yeah, definitely. But there's a huge plethora of cases that you're doing.